Good afternoon, everyone. This is Evelyn Mantilla from Access Health Connecticut. Just want to let you know we'd like to give 2 more minutes of time for other participants to log in. So hang in there with me and we will begin today's webinar in 2 minutes. Thank you. Okay, good afternoon, everyone. Let's get started with today's webinar. As I mentioned to you a minute ago, I am Evelyn Mantilla here for Access Health Connecticut. First, let me give you a little bit of information for how we are going to run today's webinar. The participants that come on are automatically muted once you're logged in. Please keep your audio muted for the duration of the webinar. We are going to reserve questions for the end of the webinar. I want to encourage you to type any questions that you have along the way on the chat box. It's located on the lower part of your control panel for GoToMeeting. If you find that your audio component is experiencing any technical difficulties or you wish to call in instead, please switch from audio to phone call in the control panel. You'll be given a phone number and access code to dial in and listen to the webinar. So today's webinar is focused on health insurance literacy. We have, as I mentioned to you, I'm Evelyn Mantilla, and I will be your moderator for today. We have a wonderful presenter today, Dr. Victor Villagra, Associate Director of the Yukon Health Disparities Institute. So without much further ado, I am going to hand over the presentation. I'm happy to present to you Dr. Villagra, who is going to give us the basics of health insurance literacy with much very interesting information. Welcome, Dr. Villagra.
Thank you very much, Evelyn, and welcome everyone. So we are going to cover this topic. I call it the basics, and I hope you'll agree with that. And I will talk a little fast so that we will have time for some Q&As at the end. Getting familiar with the controls here. I thought I would put down 4 objectives for the webinar. One is for all of us to define health insurance literacy so that we all talk the same language and understand what we mean. The second objective is to understand the benefits or, on the other side, the consequences of low or high health insurance literacy. Third is to introduce suggestions for member or client health insurance literacy education to reduce potential health or financial harms. And lastly, of course, to address any questions you might have about selection and use of health insurance once you have it. In trying to simplify the challenge of selecting and using health insurance, I built this simple formula. And the first component of the formula to the left is health insurance complexity plus low health insurance literacy plus low health insurance navigation support equals a high likelihood of poor outcomes and medical debt. And this entire equation is far worse for minorities, which leads to health inequities. And I also have to point out recent evidence to overall economic inequality. A couple of words about complexity of health insurance. The punchline is the products we have, particularly commercial insurance, are way too complex. A typical, quote, consumer-friendly subscriber agreement, and this is the document that is over 100 pages long, typically, that encodes what you are entitled to receive as benefits and what are the exclusions and things like that. So the nitty-gritty of what you're covered. So it's a long document, and a typical bronze PPO, Preferred Provider Organization plan in Connecticut, had this reading test called the Flesch-Kenkei Reading Ease, a score of 37.7, and that corresponds to a grade level 16.5, and 10 to 12 is roughly high school. So what that means is that unless you have a pretty high level of education, you may not understand everything that is contained in those 100 pages. All right, if you look to the right, we have system complexity, and I call it system because it's not just health insurance, the whole delivery system. And when I use that term, I mean doctors, hospitals, clinics, laboratories, the entire medical industrial complex, as somebody called it once upon a time. Very complex. And to the left is if you have low patient literacy or consumer health insurance literacy, then you have a big divide. And navigation support by many people, not unlike most of you on the call, are there to provide support. And you provide the kind of support that can reduce potential health harms, and specifically untimely care. We'll talk about that later on, or altogether foregone care that can result in health harm. You also help people prevent potential financial harm, economic insecurity with big fat medical bills, judicial action, particularly for medical debt, and even personal bankruptcy. As you recall, 50% of personal bankruptcies are related to medical debt. And finally, the satisfaction with the system itself, inconvenience, aggravation, and I would say underneath the satisfaction, you can elevate that to health harm in the form of anxiety, depression, some people who are simply overwhelmed because they cannot cope with the complexity and they just don't know where to turn for help. All right. What is health insurance literacy? It measures the degree to which individuals have the knowledge, ability, and confidence to find and evaluate information about health plans, select the best plan for their financial and health circumstances, and use the plan once enrolled. This is a wonderful definition, and keep it handy, and you will know what we're talking about whenever we mention the topic. Now, some people ask, is health insurance literacy the same as health literacy? Well, the answer is sort of, but not exactly. Health literacy to the right here, this sort of orange circle, is being able to understand when somebody tells you, all right, take a pill, 20 milligrams, 3 times a day on an empty stomach. Okay, you have to be somewhat health literate or literate to be able to follow those directions. Or when somebody said, oh, your blood pressure is a little high, there is a systolic number that is like 100 190. That's the upper number. And the bottom number, the diastolic pressure, is 100. And that's a little concerning. And you need to be able to understand exactly what that means, or at least approximately what that means. All that is health literacy. On the left-hand side, you all know what financial literacy is about. You need to know or have an idea of what an interest rate may be and things like that. And in the middle, there is this hybrid, this combination where you need some financial literacy, some health literacy, and be able to handle some numbers, numeracy. So as you can see, it is not totally a simple thing when we talk about health insurance literacy. All right, now let's talk about complexity. And I want to put this issue to rest. Choosing a health plan is hard, even for a health economist. I read a headline in the New York Times. Austin Frack says, a confession, I am a health economist and I cannot rationally select a health plan. He has an educational background in physics and engineering. After receiving his PhD in statistics and applied mathematics, he spent 4 years doing research and consulting for government agencies. All right, so the bar is pretty high for us to simply choose a plan rationally. And towards the end of my talk, I will mention a couple of suggestions for all of us to think about in terms of how we deal with this, because this is clearly untenable. All right, in my most optimistic moods, I put my feet up and think, well, what would be health insurance made simple? And I thought, well, it would look something like this. I don't know if you can they all see my cursor?
No, they cannot.
They cannot. Okay, to the upper left, insurance coverage, this nice lady, all she has to do is climb this ladder, which means you have to bring your tax returns, you have to know the date of birth of all your children, and at the top of this slide, you enroll in a health plan, you enter it, you pay your premiums if you're required. Medicaid, most Medicaid plans do not require it, but pay your premium and then follow the rules. That means just go back to 100 pages and understand what the rules are, and you will enter what I would consider the ideal system, which is this slide where there are no exits. It's all smooth downhill along the way. The delivery system, the doctors and the clinics and the hospitals and the labs and everybody provide safe, timely, effective, equitable, respectful, and affordable care. And voila, you come at the bottom of the slide and you have an optimal health outcomes once you mix all this with your health habits and whatever your genes endowed you with. And this is health insurance and health system made simple. There are no exits, there are no really wrong turns, and it's just a smooth ride all the way down. Well, the healthcare system as we know it today is more like this. Access to healthcare, particularly for the newly insured, is quite a challenge, but I would say for all of us is quite a challenge. If you look to the upper left, it's the same equation. You enter this maze and you hope to come out at the bottom enjoying optimal outcomes, having received the care you need. But you notice that at the bottom of this slide, I put a safety net. So we do have a safety net in the way of certain laws that provide consumer protections. There are resources if all goes wrong where you can find support and assistance. Many of those services are provided by many of you on the call. And so you play a critical role in making this extraordinarily complex system bearable to many of us. So if you want to get to the finish line, this is the path. You can find the path when you have a bird's eye view. But if you're in the middle, what you're going to do is you're going to find the pathway, but you're going to find obstacles at every step of the way. And health insurance literacy is one of your salvations. Okay, so think about it. The first thing that you may face is to say, when do I pay a copay? For all of you on the call, I'm sure that is an easy answer. You always pay a copay. But I asked somebody who I thought would know everything, do you continue to pay your copay after you meet your deductible? And she said, well, do I? I think so, but I'm not sure. All right. You keep going down to getting all the care you need. And somebody may ask, what is a premium? And we'll talk about this because as simple as you think it is for many or most, if not all of you on the call, it is not the case for a lot of people. What is a provider network? The classic on the right here. My hospital was in network, but my anesthesiologist was out of network, and I was just slapped with a big fat hospital bill or anesthesiologist bill. What is a formulary? When do I start paying deductibles? You continue down the path, and you are taking a whole bunch of medications, and they're utterly unaffordable on the left-hand side. If you stay on the left-hand side, you can end up accumulating medical debt, and we'll talk about that too. Some of you may have mothers, like I do, but who take a lot of medications because they have hypertension and diabetes and heart disease and this and that, arthritis, and they're taking anywhere between 18 and 24 pills a day. And the question is, where do I get some help, and how do I make sense out of all this? And or you may have a healthcare service that was denied payment. One of your salvations to deal with all this is health insurance literacy, or somebody like you on the call who knows that and who is insurance literate and can come to the rescue and provide some support. Okay, that is the only way that with the system we have, we will come out with a modicum of good health outcomes and equitable care. Moving on, let me tell you that we wanted to find out what was the health insurance literacy here in Connecticut. So we did a survey, and this was in 2016. We only surveyed people who had commercial insurance, qualified health plan, not Medicaid. And the first thing we wanted to know, we surveyed about 516 people. And as you can see, if your colors are the same as mine, yellow is 33% and gray is 30%. That means that about 2/3 of the population that we survey had some college or a bachelor's degree or more. That is a fairly well-educated bunch of people who enroll in through Access Health Connecticut. So given that, let me share with you some selected survey results. We have lots and lots of data, and you can get access to all these data. But in this particular question, we asked, what is the best definition of health insurance premium? And then I am showing the results by race and ethnicity. And what you can see here, that if you look at the three bars, the left is whites, the middle bar is Black non-Hispanics, African Americans, and the other one is Hispanics. Whites had the correct answer more often, but I want you to focus not only on the correct answers, but the word premium. When you hear the word premium, if you've never had insurance, health insurance, and you're not familiar with that term, well, some people chose a bonus you get at the end of the year if you stay covered. The ones in blue, which is about 1/4 to 1/5 of those surveyed, particularly among racial ethnic minorities, they think it is the best type of health insurance you can buy. And when people begin the narrative of how come minorities don't get it, well, I say they're pretty savvy, okay? Because if you've never had health insurance, let me tell you the way they might be thinking. The word premium in everyday life has at least 4 uses as a noun. It has at least 1 use as an adjective, and at least 1 use as an idiom. Housing at the bottom in that area is at a premium. Go to the adjective line. Of exceptional quality, of greater value than others of its kind, superior, a wine made of premium grapes. Or if you go to the top, number 1, a prize, a bonus, or a reward, giving us an inducement or a gift, or etc. Number 4, the excess value of one form of money over another for the same nominal value. What does that mean? Oh, I have two things that I want to sell you, but I tell you one is at a premium because the seller is very motivated. So you're getting a great deal, but at the same price as this other thing. That is a premium. So people out there who are trying to interpret the word premium, and in this case have to answer a question, may not think that the definition that used by insurance companies is exactly the way they're supposed to use that term and then pay premiums, even if they don't see the doctor, for example. All right, I'm going to share a few other results. Definition of deductible. Before you look at the answer, if I mention the word deductible to anybody in my neighborhood, they're going to think, oh, you deduct something from your paycheck, or you deduct something from your taxes. Okay, why not? The correct answer, you all know, is there underlined, but in orange, the amount of health expenses that you can subtract from income of your yearly tax return is not really a bad choice. If you have never been insured, you don't know exactly, you didn't read 100 pages of the agreement, or the amount that is deducted from your paycheck each year to pay for your policy. I don't think that would be a bad choice if I had to guess, like people in the survey did. But you can see that pervasive racial ethnic disparities are very clear when it comes to knowledge of this vocabulary, and you'll see in a minute on understanding of how to use the concept themselves. Very quickly, best definition of provider network. Well, what would be a provider network for an uninitiated in insurance? The orange says a website where consumers can find information about best doctors. Again, not an unreasonable answer. Or the next one, in blue, the computer system doctors and hospitals use to submit bills to insurance companies. The print is a little small on my computer, so I'm having to put my nose really close to the screen here. And to the right, you can see that provider network, for those who took the survey in English, a much higher percentage of people answered the question correctly or chose the correct answer than those who took it in Spanish. So language makes a difference, a big difference. And if you don't know exactly what an insurance or provider network is, it can cost you in health and it can cost you in economic currencies, on both. All right, that's why health insurance literacy really matters. Now, some of you may have seen this example that I've used before. We asked this question: suppose under your health insurance policy, hospital expenses are subject to $1,000 deductible and $250 per day copay. You get sick, you're hospitalized for 4 days, and the bill comes to $6,000. How much of the hospital bill do you have to pay yourself? Well, for most of you on the call, if not all of you on the call, you just look at two numbers, 4 and 250. 4 days, $250 a day copay, no problem, $1,000. And $1,000 deductible, the correct answer is at the bottom, is $2,000. That's what you have to pay out of pocket. Easy for most of you, not all of you. But only a third of the people we surveyed got the correct answer. Some thought that it would be zero. Some people thought it would be 4,000 or 6,000. And you may think, well, so what? Okay, so you cannot calculate how much you would have to pay out of pocket. But suppose for a minute that your doctor told you, oh, this is the third gallbladder attack you've had in the last 2 years, and I think you need to get it out. We need to do an operation, because one of these days you get into big trouble when that gallbladder really gives you a horrible attack and you turn yellow and bad things are going to happen. Well, if you are looking at 4 days in the hospital, which probably won't be that long, but you think you're going to pay zero for that admission, okay, you may be surprised when you get a surprise medical bill for $2,000 that you did not anticipate because you didn't understand how deductibles and copays can be used in combination. Or you may have chosen 6,000, in which case you may say, 3 gallbladder attacks, I don't have $6,000 put away, and I don't want to be in debt, okay? And so what you think is going to be your liability is not correct. And so you postpone your gallbladder surgery and see how much luck you have. And that is a dangerous proposition. So there are consequences to low health insurance literacy, to low numeracy, and the more complicated we make it, the more people get tripped along the way, and their health and their financial situation can worsen. All right, now, I was thinking, so how can you overcome some of this? Well, one of the skills of a health insurance literate person is to be able to find the information somewhere, okay, because you cannot have it all in your head. So I went to the Aetna site. I apologize, I don't have the label that shows that it's an Aetna slide that I'm showing you, but the website link at the bottom says Aetna. And I said, well, suppose I am obese and I want to have, I put stomach stapling. I try to use the least technical nomenclature to find out if I would be covered. I could have used bariatric surgery, which is the medical term, or I could have used weight loss surgery. But whatever your question is at this wonderful Aetna site, in 0.078 seconds, you have 79 results. But the top of it says obesity surgery. All right? So that was great. But the one thing I have to tell you is I had to click 5 different things before I got to this, and because I know exactly how to do that. That is my health insurance literacy capability that enables me to get to that. Now, I need to know if I will be covered. On the left-hand side, I won't go over it of this slide. It gives you an explanation of what these clinical policy bulletins are, but this is when you would be covered. You must, it depends if you're an adult or an adolescent at the top of the right-hand side of the slide. If you're an adult, you need to be 18 years of age or older and have persistent severe obesity documented in medical records. Now I'm going to go to A, body mass index exceeding 40. I don't know how many of you can calculate or know exactly what that means. Or you could have a BMI of 35 in conjunction with the following, and I will go to 1, 2, 3, and 4. You can have that plus sleep apnea, or B or second there, coronary artery disease, with objective documentation. It goes on and on and on. Exercise, radionuclide stress, pharmacology. Then number 3, medically refractory hypertension. Number 4, type 2 diabetes. Well, if you meet these criteria, you are covered. You can have your bariatric surgery or your weight loss surgery, and because you're older than 18, you're covered. This is what is contained in 100 pages, or these are the resources that you can find if you are health insurance literacy. Now we are in the using health insurance, not getting health insurance. So what needs to be done? We need to know what is the health insurance literacy level in Connecticut. The Health Disparities Institute did that survey because we wanted to find out. And the news is, generally speaking, is modest, and racial ethnic minorities and those who are have limited proficiency in English are at a disadvantage. The second is we need to test the best way to teach health insurance literacy to consumers in ways that are culturally and linguistically appropriate. Kelly Kennedy is here with me, and she's a community affairs and outreach manager at Access Health Connecticut, and she asked a very smart question: what are the best practices in terms of teaching health insurance literacy? And the answer is, well, it depends on your audience, and that is correct, as you can see from the survey, that it really depends on who your audience is. But I also want to say that we at the Health Disparities Institute are researching this very good question that Kelly asked, and hopefully we will have some answers for you in the not too distant future. The third bullet point here says policy change that will require basic health insurance literacy education starting in high school. The fourth is policy change to simplify health insurance. This is probably one of the most important things that we can do, because the simpler we make it, the less onerous the health insurance literacy education will be, because it will be simpler. And we'll talk about what that means in the next future slides. And finally, community-based organizations need to continuously educate patients about health insurance language and concept. What that means is that all of you who are in this webinar need to continue to work on enhancing your own health insurance literacy, education, and your ability to counsel and support those who you work with in the community. Consumer protections and patient support for public policies is another thing that we can do. Again, surprise medical bills, we have made very good strides here in Connecticut. The out-of-network, in-network discrepancy. The elimination of complex cost-sharing schemas. I think for as long as we have these complex deductibles and co-insurance rules that apply to some things but not to others, to some drugs but not others, we are simply inviting mistakes. And by the way, consumers are not the only ones who are getting in trouble and making mistakes that are costly, but providers themselves are confused and they don't like the excess complexity of the system. The third bullet point here says public funding for health insurance literacy education. I already mentioned that. The next bullet point is for community health workers working in impoverished communities. I don't know how many of you work with or are community health workers. If you are, you're doing God's work out there. It's fabulous. And I think you need to be supported. You need more opportunities for professional development. And I would say permanent funding is a must. Legal assistance for defendants in medical debt claims court is also extremely important. And in a minute, I'll tell you why that matters. All right. I have a long list of consumer resources. I just mentioned a few of my favorite here. The first bullet point says have patient health insurance literacy resources in the office or your website, pamphlets, videos. The first YouTube video there is actually from Kaiser. And you can say it's fairly generic. I encourage you to click on it and take a look at it's an animated explanation of a particular HMO type of plan that explains some of this terminology. The second one that I like very much is called GoodRx. And I'll give you an example of how, if you are health insurance literate, you can use GoodRx to your benefit or the benefits of your clients or your relatives. The other one is called Healthcare Blue Book. You know, the car blue book where you compare prices for cars and what year and what model and what color. Well, Healthcare Blue Book, you can put your zip code and it will give you what is the average or fair price of a particular doctor's visit or a test in your region. And while it is not precise because they don't know what exactly is your plan, it will put you in the ballpark of what is a fair price to pay for, say, a mammography or, you can also, and I encourage all of you to have handy the Office of the Healthcare Advocate phone number and information email there. This is a fabulous resource that the state provides, and you can also use that as a consumer resource. I would say something that we need very badly is the next bullet point, and that is transparency in medical billing. I tell you, beware of, quote, summary bills, which is what we all get. And be prepared to ask for an itemized hospital bill that can be very long and very confusing. I grant you that. But ask for help scrutinizing them before you pay. Let's say you go to the supermarket. You're checking out, you have a cart full of groceries, and your bill says meats, X dollars. Produce, X dollars. Fluids, X dollars. And then there's your total. You would never pay that bill. Or if you go to a restaurant and they give you a bill and you don't know how much you paid for wine, how much you paid for your entree, how much you paid for your salad, and how much you paid for dessert. They give you an itemized bill because you are entitled to it and because it is the business practice in our country and every country that I've been to. So beware of summary bills because a large number of hospital bills have errors. And if you are made accountable to pay for the balance of that bill, you have to pay, including the error. The insurance company does not scrutinize all of these bills at the level of detail that needs to be scrutinized to prevent you from having to pay a balanced bill that includes errors. So start thinking about that. We will come back to this theme in the next few months because we're going to study medical debt in more depth. All right, moving on. This is a busy slide, and let me help you orient yourself. I want you to focus on the upper left red square or rectangle, and the title of the slide is Health Insurance Literacy to Beat High Drug Prices. For example, you have to know what generic is and what a brand name is. All of you on the call know that, but your clients may not. And you also need to be aware of the next layer of the onion, and it is the case of combination drugs. Let's say a doctor prescribes you a drug called Duexis. The print on my slide is very small, but Duexis is a drug that if you follow the arrow, will tell you the price. This is GoodRx, by the way, $830.16. Halfway down the arrow, it says 30 tablets. And after Duexis, it tells you that this is a combination of ibuprofen and famotidine. Okay, I cannot read the fine print here on my computer, but famotidine and ibuprofen, $830. Now let's go to the right. Ibuprofen is Motrin, okay? And you can get ibuprofen generic. And GoodRx will tell you can go to Walmart, upper right box, or you can go to Kroger's and you can pay $4 and halfway down the arrow for 30 tablets, $4 versus $830 for the first component of Duexis. And if you come down to the lower right, it says famotidine, which is the other component of Duexis, and it tells you that you can go to Walmart and Kroger's and you can buy it for $4. Now, I can tell you that you can take 2 pills, 1 ibuprofen and 1 famotidine, and you're going to be taking something very close to Duexis. And I have a disclaimer here because I am not making medical recommendations in this webinar. I think you all should consult your provider or tell your clients to consult their provider before making any changes in your medication. That is sound legal advice. But the truth of the matter is that there are many drugs, or a number of drugs, that are priced outrageously. Like in this case, the left lower corner gives you another example. There is a drug called Treximet, 9 tablets, $822, okay? And Treximet is a combination of naproxen in green ink or Aleve, which you can buy for $2.55 for 14 tablets. So you have 5 more to spare. And sumatriptan, which is the second component of Treximet or Imitrex, that you can buy for $14.54, 9 tablets. And then GoodRx.com tells you to make your own Treximet equivalent, you can take 500 milligrams of naproxen and 1.5 tablets of generic cheap 50 milligrams of sumatriptan. Does swallowing what Treximet pill work better than taking a naproxen and sumatriptan at the same time? There is no proof that it does. And why would it really? It's a great question. There's another drug. I may have misspelled it here. Acania, I think it's with an N. That is a cream, clindamycin 1%, benzoyl peroxide. This is 2.5%. You can buy a tube that is the equivalent of buying sort of a medium-sized toothpaste tube for $546, or you can get clindamycin, the first component, anywhere between $4 and $10 in green ink there, or through a generic, or you can buy 30 grams tube of benzoyl peroxide, the same 2.5%, for as low as $15. All right, this is health insurance literacy a couple of layers down from deductibles and co-pays and coinsurance, it can make a huge difference, okay? And since pharmaceutical companies really don't like to make comparative effectiveness studies that compare one with the other, and the halftime Super Bowl commercial that tells you to use Jublia for your toenail fungus at an outrageous price where you can get something that works better at a fraction of the cost, that will not appear in the Super Bowl commercial. Health insurance literacy matters a lot. And the more educated you become, the better off you're going to be and the better off your clients will be. So what do I tell providers? I talk to doctors, and the first thing is collaborate with your insurance companies, okay? It does you no good to cast anybody out there as the good guys and the bad guys. Find common ground. Simplify and expedite the prior authorization process. I'm not going to explain the prior authorization process, but if any of you have questions, ask it at the end of my presentation, and we'll talk about it. Leverage resources such as disease and our case management services. I can tell you that insurance companies put case managers, the closest equivalent to a community health workers, but these are very smart men and women who are working in hospitals, and make sure that if you've had everything you need while you're in the hospital done, except the result of one test, and it's Friday at noon, that case manager is going to chase that doctor and say, what was the result of that one last test? Because if we don't get it, this patient will sit in a bed Saturday and Sunday at the tune of $1,800 a day, and the insurance company will have to pay for a discharge on Monday once the result pops up on the computer screen. So there's so many things that can be done to make healthcare more affordable. I'm just scratching the surface. Offer patients all the preventive services appropriate for age, sex cover under the Affordable Care Act with no out-of-pocket cost, okay? Educate hospital and clinical staff about health insurance to help patients avoid these pitfalls. These things are not a good deal for providers either when consumers make mistakes, and of course when they make mistakes. It says here, screening versus diagnostic colonoscopy. Let me tell you, the time came when I had to have my colonoscopy, so I went to the gastroenterologist, and when I left and I got my appointment, I talked to the receptionist and I said, how are you going to code my colonoscopy? And she said, the same I usually do. And I said, well, what does that mean? Preventive? She said, yeah, of course. And said, okay. And I said, what happens if the doctor finds a polyp or 2 or 3 polyps, which is very common, and they remove the polyp, and that polyp goes in a bottle to the pathologist, and the pathologist has to figure out if it is precancerous or cancerous or benign, and I'm going to get a bill from the pathologist because now, is that preventive or is that not preventive? And this wonderful person was looking at me like, what are you talking about? I said, I just want to know. I want to prevent a medical bill that I am not going to pay. But I am a busy guy and I'm not going to, let's just deal with it up front. She had no clue, okay? So you have to know that these things happen. The same thing with any other mammography, other test, okay? By the way, I paid $0. And they did find polyps and they were all fine. Identify patients with accumulating debt and offer alternative payment options before you send a collection agency. For goodness sakes, docs and clinics, work with the patient, figure out how they can pay you maybe on a weekly or monthly basis. And depending on what the charges are, well, maybe even consider, is this unreasonably expensive, and what can you do for your patients? And the reason I mention this, because some of you may have seen these slides, these are records from the small claims court in Connecticut from the judicial system. Between 2011 and 2015, the top graph all the way to the left of that dotted line, red line, up and down, that's when the Affordable Care Act really kicked in halfway into 2013 after the first open enrollment. I figure all these people have had time to go to the doctor and accumulate some debt. Let's see what happened with the Affordable Care Act. And the top number shows the total number of small claim cases, 85,135 cases in these 4 years. Okay, and you can see after the Affordable Care Act, it came down a little bit because, of course, there were fewer uninsured people. Now, if you look at the dollars that were involved in this medical debt situation in these years, $110 million. This is a huge financial burden for the most disadvantaged in our society because it's typically racial, ethnic minorities, low income, or folks who don't speak English who end up in court. So I tell the docs, look, there are benefits to your practice from being thoughtful about how you approach your practice. Number one, if you're careful about what you prescribe, it enhances the patient trust. Because can a patient, the bullet point under enhances patient trust, can a patient who has been taken to court by their provider or hospital will trust them? Again, I don't know the answer, but we're researching that by, I say in the old days, patients used to sue doctors. More and more doctors are suing patients, and that cannot be good for patient-physician trust. It avoids potential conflict of agency. Agency meaning you are advocating, you are on the side of the patient. But in all fairness to the doctors, they have to find a balance between the practice, financial stability, and patient's best interest. So it's a matter of being aware and being conscientious about how you handle these matters. It enhances the practice financial performance. Of course, it enhances the patient, the practice financial performance, because if you are careful about prescribing things that are affordable, generic medications, 2 pills that are equivalent to 1 pill, for example, those kinds of things that we doctors are not really taught to think about very much, but are becoming increasingly aware of, it improves your collection rate, and it reduces the magnitude and the longevity of something that practices call accounts receivable. That's a whole bunch of services rendered, but they have not collected yet. And that can be a problem for the practice because they get into cash flow problems. And lastly, continuity and quality of care. A patient taken to court may simply be lost to follow-up. That means I'm not going back to that doctor because the last time I heard from him, I was summoned to court. And so these are the cases that reappear in the emergency room with totally preventable conditions that should have been taken care of a long time ago. Okay, moving on, and I'm almost done here. What are some of the solutions to selecting and using health insurance? I would say under the health insurance complexity, the red arrow says fewer but better health insurance product choices. We don't need 55, which was the first time I checked under Access Health Connecticut. We don't need 55 choices. We also need improved labeling. Bronze, silver, gold, and platinum are not very good labels because all of these are value laden. Like a gold medal is better than a silver medal and is better than a bronze medal. But when it comes to your health, your financial situation, and your health needs, silver or bronze could be a better choice for you depending on your overall health and your financial situation. So fortunately, Access Health Connecticut and others are providing decision support tools that help that decision. The second, under health insurance literacy, I pretty much elaborated on all this. I would love to see a lot more resources for everybody on this call so that we can all talk about this more frequently and in more depth. And I'm hinting some of that depth with some of my examples. And lastly, improve navigation support by providing training and stable funding for community health workers and others who, as I said, are doing God's work there helping consumers. And this will not eliminate poor health outcomes or medical debt, but it would certainly go a long ways towards reducing healthcare disparities and reducing economic inequality. All right. With that, I'm going to pause and give it back to Evelyn.
Thank you so much, Dr. Villagra. Before we go to the questions, I'm just going to do a little bit of a part of my job, which is to have a little pitch about becoming partners with Access Health Connecticut. I'll do this very quickly because I suspect that some of the folks that we have on the webinar are in fact already partners with Access Health Connecticut. But very quickly wanted to show you that we have partners and we are always looking for partner organizations that can share information about access to health coverage with communities all over the state of Connecticut. We provide the resources as Access Health Connecticut, and we invite dialogue with our partners. You can see here some of our community partners, which include faith organizations, community health centers, the Department of Labor, health departments, and such. This map right here shows you how the breadth of our reach with community partners, which is why we want to continue to grow and deepen our relationships with our community partners. This map can be even more filled, be sure that we reach the communities that really need us. I'm not going to go through all the details here, but there are ways that we can be helpful to you. We can go to events and present information. We can do training sessions. We can hold webinars such as today, and we can provide materials that you can distribute to your community. Additionally, some of the ways in which you can help Access Health Connecticut are placing information in your office, providing some of our materials to your clients as you serve them, and you can also link to us through our website and share information on social media. Engaging our community is extremely important to Access Health Connecticut. This is why we provide the information that we are providing today in the webinar. And we do have a number of resources. I'm going to give you in a moment, especially the one that I want people to always pay attention to is our community website. If you go to learn.accesshealthct.com/community, we've created this website to basically have a plethora of information that is helpful to you. You can download our flyers. You can look for more detailed information that you need for your clients. So stay connected to the website. I always remind everyone of that. And last but not least, our contact information. We are part of a rather sizable outreach team. Our job is to get to you as our community partners and to get to the communities that we want to serve. You can call us at this number, 860-327-5517, and you will reach directly into the outreach team. You can also email us at outreach@accesshealthct.com, and of course, visit the website that I mentioned, learn.accesshealthct.com/community. So, having made my pitch, let's go to some questions to Dr. Villagra. For anyone that has a detailed question, please put it in the chat box on the lower right-hand side of the control panel. And we also have some questions that have been presented before. So do go ahead and type any questions you may have. And while we do that, let's talk about a little bit of some of the things that some of the participants asked us before. One of them is, Dr. Villagra, where can providers get more health literacy training in Connecticut?
Well, the Health Disparities Institute created something called the Equal Coverage to Care Coalition. The Equal Coverage to Care Coalition has now, I think, upwards of 20 member organizations. Some of them have applied and received research and education grants to test health insurance literacy in their respective communities. And we're wrapping up that project now so that we'll have some answered for Kelly and some of you. The Health Disparities Institute is one place. The other place that I would encourage everybody to check is actually your insurance company. We're a little more familiar with Connecticut. We've done some work with them. They've been a wonderful collaborator, and they have excellent health insurance literacy and navigation information and tools there. And then, of course, I put down some of the resources that I personally use. There's a lot more where that came from. And so we are trying to make those available at the Health Disparities Institute website. And having said that, we're in the middle of renovating that website. So give us a week or two and we will have a new one with additional resources.
That's great. Wonderful. Thank you. Thank you, Dr. Villagra. And we do appreciate the work of the Health Disparities Institute, and it's just really making a difference among other partners to get this information to providers who in turn can get it to their clients. That is just a huge service that can help all of us increase health outcomes in the communities that we so care about. Before I go on to the next question, I want to remind or really tell people for the first time, we really like to know how we do with these webinars. So I am going to encourage you on the chat box. You will see that our friend Grace posted a link, and that link is to a very short survey that will ask you a couple of questions about how we did today. So take a moment before we finish the webinar and click on that link and tell us what you thought about today. Don't forget, click on the link and let us know your opinion. It really helps us make these services better and better as we go along. One of the questions we have, Dr. Villagra, is what are the best ways to make education on health equity literacy a part of the enrollment process? What would you recommend as we enroll consumers?
Well, I think concentrating on the basics, which Access Health Connecticut has done in the past, and I know you have all focused on that, and I know you have focused on linguistic and cultural competency as part of that. But I would say this is a process that needs to start long before anybody enrolls. First of all, the information, the laws, the policies, as we all know, are changing, sometimes unpredictably, and that makes it hard. But we feel that the basics of health insurance literacy needs to start as early as high school years, because pretty soon kids will go to college, and while they will be covered by mom and dad, unless things change, or parents in general, until age 26. The current mood seems to be to allow market forces to dictate how people will gain access to health insurance, and cutbacks on subsidies and Medicaid eligibility may end up sending more and more people to private health insurance. I can tell you, if you enter the world of private commercial health insurance and you haven't had a modicum of health insurance literacy, you're going to enter the most complex labyrinth of jargon and rules and exceptions you've ever seen. So let's start early.
Absolutely, absolutely. Thank you. Thank you again, Dr. Villagra. I'll encourage you to ask any other questions you may have on the chat box. I will remind you once again, the link for our short survey is on the chat box as well, and we really would like to know, how did we do today? What did you get out of participating in our webinar? So do participate. It will take you but a couple of minutes. Anything else that I wanted to make sure that we covered? I think that I'm not seeing any other questions coming in through the chat box. So it looks to me like we can close the webinar. I want to first and foremost thank everybody for participating, taking the hour of your workday today to get this very important information. Really means a lot to us. And I have a very special thank you to Dr. Villagra because the work that is happening in the Health Disparities Institute, as well as those who really care about this issue, is really going to make a difference over the long run. And I do mean the long run because it's a slow process, isn't it? But we know that we can get this information in the hands of the consumers more and more each year and make sure that everybody is treated fairly and is able to best benefit and have the best health outcomes. So thank you again, Dr. Villagra. Really appreciate your time.
Thank you for having me.
Thank you for everyone for participating. If you didn't click on the link for the survey yet, do that now. And with that, I will say good afternoon, goodbye to everyone, and we hope you enjoyed today's webinar. Thank you. Thank you again from Access Health Connecticut.